Professor Dominguez Munoz, I think you can start.
I'm trying to share my screen, but I cannot yet. Okay, that's fine. Just to use my background to say you hello and welcome to the Viatris Sponsor Symposium on Hot Topics in Pancreatic Exocrine Insufficiency. And as you can see in the title, that will be a fully different symposium. So we will not have a list of a row of presentations with some few Q&A seconds after that. We will have a roundtable to diagnose, to discuss about the diagnosis and treatment of PI in clinical practice. You know, over the last years at the EPC, we have been presenting on the diagnosis and the therapy of pancreatic exocrine insufficiency in different clinical conditions. We have been presenting on chronic pancreatitis, after pancreatic surgery, pancreatic cancer, and so on. And at the end of the day, if you see all the papers evaluating the percentage of doctors, practical doctors that meet the clinical guidelines, that percentage is quite low. And still today, there are a lot of open questions when you deal with a patient with the clinical suspicion of pancreatic exocrine insufficiency, how to make the diagnosis and how to treat it. The idea today is to try to answer to all these practical questions. Therefore, my first message is, you are a very important part of this symposium. Please post your questions when you want, because we will try to answer them during the symposium. This is a quite challenging symposium. You know why? Because first of all, it's live. It is not recorded. And secondly, because it's completely different to any other symposium. So it's quite challenging. But if I tell you the truth, any challenge is very simple if you have a group of panelists as the one that we have today. And I will introduce them later, but they don't need any kind of introduction. We have today with us Matthias Löhr, we have today Vincent Rebout, and I hope that we will have Marco Bruno as well. And before starting with the discussion or with the questions, let me introduce the topic. Sorry. Well, this is the disclaimer. I should not tell you, this is a Viatris sponsored symposium, but obviously everything that we will say, our statements depends on us. This is nothing, they have nothing to do with Viatris. And the first point, very important, critical point is, what are we talking about? Look, very recently, the British guidelines define PEI as a reduction of pancreatic exocrine activity in the intestine at a level that prevents normal digestion. Look, this is a very important definition. You know why? Because we are talking about a reduction of secretion, but associated with a maldigestion, preventing normal digestion. I have changed a bit that definition. What you see below is my opinion. You don't need to agree with that. And we can talk about a failure of the exocrine pancreas to deliver the required amount of enzymes to the intestinal lumen for a normal digestion of the ingested food. So I introduce here for discussion a third factor playing a role in PI, which is the ingested food. It is not the same, you will agree with me, to digest a small low caloric food compared to a large caloric fatty meal. So it is completely different. So we are talking about a reduction of pancreatic secretion, preventing a normal digestion. And if we talk about it, maldigestion, you know, is associated with malabsorption of nutrients, and therefore patients with PI will present with symptoms of malabsorption, diarrhea, abdominal distension, abdominal cramps, noises, flatulence, and so on, and nutritional deficiencies. When we talk about PI, we are not just talking about a reduction of pancreatic secretion. We are now talking about malabsorption of nutrients, symptoms, and nutritional deficiencies. This is really more important than you can really believe. You know why? If you have a look into PubMed and you write, for example, on your left, fecal elastase, you will see that the majority of the authors classify their patients in their studies into mild, moderate, or severe pancreatic exocrine insufficiency according to the result of fecal elastase. Fecal elastase is a test quantifying pancreatic secretion, not digestion. But despite that, we have been talking about PEI according to the result of fecal elastase. This is something that we will discuss later on. And you know very well the graphic on your right. That graphic was published for the first time by Jean DiMagno in the 70s in Rochester in the Mayo Clinic in patients with chronic pancreatitis. And here 100% is normal pancreatic secretion. And this is again in chronic pancreatitis. And you see when the pancreatic secretion comes down, declines even to 20%, nothing happens in fecal fat. That means people with a 20% of the normal secretion still may digest fat and nutrients quite normally. And only when pancreatic secretion is below 10%, steatorrhea develops. This is the study that gave origin to the concept of the huge reserve capacity of the exocrine pancreas. And if I tell you the truth, although we agree with that, this is not so simple. You know why? Because there are many other factors influencing the concept of pancreatic exocrine insufficiency, and pancreatic secretion is just one of these factors. But what about the gut? What about the intestinal pH, intraluminal pH? You know that enzyme activity, pancreatic enzyme activity is closely related to the pH in the gut. What about intestinal anatomy? It is the same someone that has been operated on, or someone with a normal anatomy? And what about intestinal function in terms of compensatory mechanisms? We have salivary amylase, we have pepsin in the stomach, we have gastric lipase, and we have enzymes in the gut. Can these compensatory mechanisms influence the concept of pancreatic exocrine insufficiency? And of course, what about the disease-causing PI? Is it the same pancreatic cancer than patients after acute pancreatitis, for example? Obviously not. And finally, important factors are the dietary habits and the nutritional needs of the patients. Therefore, the concept of pancreatic exocrine insufficiency is much more complex than we have considered before. And the question today, and we will discuss about it later on, is how relevant is each one of these factors in the diagnostic and therapeutic approach of PI in clinical practice? Because the idea today is to discuss about clinical practice. You know that there are different causes of PI. Any pancreatic disease can cause pancreatic exocrine insufficiency, chronic acute pancreatitis, cystic fibrosis, pancreatic cancer, diabetes mellitus, and pancreatic surgery, but also gastric surgery. Gastric bypass, gastrectomy can lead to pancreatic exocrine insufficiency, and even patients with gut diseases like celiac disease. Look, what are the mechanisms of PI? You know, in people with pancreatic diseases, the mechanism is a reduction of the secretion, pancreatic secretion of pancreatic enzymes and bicarbonate. And therefore, the problem is not just a decrease in amount of enzymes in the gut. It is a problem of a decreasing of enzyme activity in the intestinal lumen due to a low secretion of pancreatic enzymes, but also to a low intestinal pH, secondary to the decrease of bicarbonate secretion by the pancreas. If we move to the anatomy in patients after surgery, for example, after pancreatic duodenectomy or duodenopancreatectomy, you will see that it is not only a matter of a low pancreatic secretion of enzymes and bicarbonate, but it is also an inadequate mixing due to the GI reconstruction, an inadequate mixing of the chyme with enzymes leading to pancreatic exocrine insufficiency. So what I wanted to tell you today is that we have different causes. We have different mechanisms of PI. We have different severity of PI. Not everyone is the same. We have different clinical consequences. It is not the same PI in chronic pancreatitis than in pancreatic cancer. We have patients with different dietary habits and different nutritional needs, and therefore PEI should be different in different patients. And that should lead theoretically, and this is what I want to discuss today, to a different diagnostic and therapeutic approach. So you know that to make the diagnosis of PI in clinical practice, we have different options, and we normally evaluate as much as we can. We evaluate symptoms, as I told you before. We evaluate nutritional markers, a pancreatic function test. I say here fecal elastase because it's the one that everyone uses. And we could even include here, if you like, the clinical response to pancreatic enzyme replacement therapy as part of our diagnostic approach. But there are a lot of open questions in clinical practice. So how should these diagnostic tools be used in clinical practice? What is the role of pancreatic function test in this context? How to interpret the fecal elastase results? What about when we get a low fecal elastase result in a patient who is symptom-free with normal nutritional status, or vice versa? Should the diagnostic approach be different in different patients according to the cause of PI or according to the GI anatomy, for example, patients that were operated on or not? And does the pre-test probability, before we do anything, the pre-test probability of PI influence in any way the diagnostic approach to PI in different clinical conditions? Open questions that I would like to discuss today. And look, this is what has been reported in the literature. This is how likely is PEI in different clinical conditions. In chronic pancreatitis may range from 10 to 20% in non-calcific disease to more than 80% in chronic calcifying pancreatitis. After acute pancreatitis, we can talk about 20% in edematous disease or higher than 50% in patients after necrotizing pancreatitis. Pancreatic cancer, you know that the probability of PI is very high, higher than 70%. But look, if the tumor is located in the head of the pancreas, the probability of PI is 3.36 times higher compared to patients with a tumor located in the body or tail of the pancreas. And after surgery, after PD, you know that the prevalence of pancreatic exocrine insufficiency is very high, even higher than 90%. And after left resection is very variable from 18 to 80%, as has been reported in the literature, basically depending on the quality and volume of the remnant pancreas. And finally, you know that the therapy is based mainly on two main pillars. The diet, nutritional support is one important pillar, and the other is pancreatic enzyme replacement therapy. You know the recommended initial dose. This is what has been reported in clinical trials and in clinical guidelines, sorry. And usually we recommend an initial dose of 40 to 50,000 units with main meals, half that dose with snacks, and usually enzymes preparations in form of enteric-coated microspheres, mini microspheres, microtablets, some pellets. And again, and with that slide, I finished. There are a lot of open questions that I wanted to discuss with you today. So what dietary recommendations? And when should PERT, pancreatic enzyme replacement therapy, be indicated? Should we treat every single patient with pancreatic exocrine insufficiency? Should we always prescribe enzymes? Or there are some exclusion criteria, if you like, to the treatment? Should the initially prescribed dose be the same for every patient? What we have been talking about, 40 to 50,000 to everyone? Or should the dose be tailored according to the disease that causes PI, or according to the nutritional needs, or according to the GI anatomy? Are these factors influencing our decision to prescribe a certain amount of initial enzymes? How often should these patients be monitored? Should we monitor symptom relief? Is that enough? What is the role of nutritional markers in the follow-up of patients with pancreatic exocrine insufficiency? What is the role of pancreatic function test in monitoring the efficacy of pancreatic enzyme replacement therapy? And what to do if that initial dose that we have been talking about is not enough? Should we inhibit gastric acid secretion? When and how? Should we increase the dose of enzymes? When and how? And when and how should we exclude other diseases or conditions potentially explaining the poor clinical response to pancreatic enzyme replacement therapy. A lot of open questions that we will discuss just now. And I told you before that it's my pleasure to share this symposium with real expert pancreatologists. You know all of them very well, and real experts in pancreatic exocrine insufficiency, and also experts in clinical practice. So everything together is my pleasure to have today with us Vinciane Reboul. You know her very well, past president of the EPC, head of the pancreatology and digestive oncology department at the Bouillon Hospital. You know Marco Bruno very well. He's the chief of the department of gastroenterology at the Erasmus University in Rotterdam. And obviously Matthias Löhr, professor of gastroenterology at the Karolinska University. So with that, I finished my introduction and we will start discussing. I will open the chat just to read the questions coming from the audience. And again, I tell to all of you participants, you are the most important part of this symposium because the idea is to answer clinical questions important for you. And hello to all of you again. And let me start by talking about the definition of pancreatic exocrine insufficiency, because over the last years, we switched from a reduced pancreatic secretion to a concept of, yes, reduced pancreatic secretion, but for what? For maintaining a normal digestion. So a reduced secretion that prevents a normal digestion. Who wants to be the first? Matthias, please.
Obviously, I can say something about that. And then maybe we could, after we have discussed the definition, go over to follow the journey of a putative patient through diagnosis and all of that. I think that the concept which actually was introduced by you, Enrique, by using the breath test in a very clever way is something which in clinical practice is really, one can say a change in how we pursue exocrine pancreatic insufficiency, not just from a mere production of enzymes in a given patient, but taking into account all the other factors which then will contribute to the digestion and the effect of that digestion with regard to the patient. Okay, so I think this is this definition of pancreatic exocrine insufficiency being more in effect maldigestion and malnutrition is really something which we have to promote rather than just looking at the production of pancreatic enzymes by the gland. The best example actually are those who are operated where, say, the pancreatic gland is completely normal, but then due to a variety of factors which we can discuss, the gland does not function any longer. Or the anatomy prevents the activity, which then underscores the fact that it's not just the capacity of the gland to produce the enzymes, but really what's coming out of it and how to digest the food in the end.
So Marco, in my opinion, we are discussing a very key aspect of pancreatic exocrine insufficiency. Should we, according to your opinion, should we include the dietary habits and the dietary needs, the nutritional needs of patients as part of the concept of PI? What do you think?
No, because we have to look, we have to look at patients in their daily practical, how they function in their daily lives, how they eat, what kind of eating habits they have, and that differs greatly between patients. Exactly as was already told. That's one of the reasons why I'm very much in favor sometimes of doing a simple, but a fecal fat balance test. Because in many cases, that provides me with much more information than just doing repetitive fecal elastase test, which I think it's a very handy test, but it's a very overrated test with regards to interpretation. And sometimes to persuade a patient to take the effort to do a fecal diet fecal sample test for 2 days run-in and 2 days collection gives you a lot of information with regards to the severity of the maldigestion that's ongoing.
We will discuss about it later on because this is a very important topic, because this test is, I fully agree with you, but the specificity is not so high. So we will talk about it later on, talking about the diagnosis. You open a very important point now. But Vincian, still talking about the concept of PI, because I think we are making steps very important in order to understand more what we are talking about. Should we also talk, or should we also include aspects like pH in the gut, anatomy, compensatory mechanisms? Because not every patient is the same. To what extent should these factors, which are very important in our clinical practice, to what extent should we include these aspects in the concept of pancreatic exocrine insufficiency?
Yes, I do agree with what you said. I think that we can not just judge pancreatic insufficiency just regarding elastasis dosage, for example, because we have all example of patients which have exactly the same dosage and completely different symptoms and completely different complication. So the complication and secretion, pancreatic secretion, could be different, and regarding patients, because we are all different for exactly the same disease or the same stage of the same disease, and could be also be balanced by, as you said, anatomy, if there is some surgery, if there is some physiology we are changed because of other disease, we will probably talk about that, and change of the anatomy. So we can assume that the diagnosis for me of pancreatic insufficiency, it's clearly can be managed by elastase dosage, but not also this dosage, but by symptoms, and have to be balanced by anatomical changes, for example, if there is some surgery, and regarding also to the disease. I mean, it's not exactly the same, as you said. If it is just chronic pancreatitis with mainly calcification and atrophia, it's not the same in a patient with pancreatic cancer in the head, with chemotherapy and some interaction with other treatment. So yes, I think that we have to manage the patient in globality, and to take all these parameters into account, just to confirm the diagnosis.
You know, I'm trying to be a bit provocative, because obviously a certain amount of enzymes secreted by the pancreas may be more or less effective in digesting the food, depending on the pH in the gut, depending on the anatomy, and depending on other factors. But we are making things very complicated in clinical practice, for clinical practice. Talking about this concept makes really difficult to make the diagnosis of PI in clinical practice. I fully agree with the concept. Now we need to move, if you like, to real life and to the time where we have a patient seated in front of us in our office, in our pancreas unit. So, and the first question, and I can come back to Matthias if you like, is when is the diagnostic workup of PI indicated? I have a patient sitting in front of us, in front of me. What kind of patient should be in order that I said, okay, that patient may have PI, let me try to diagnose it or to exclude it?
I was just noting this down, Enrique, before the definition really, and maybe the European Pancreatic Club is a little bit beyond that. Obviously, we need to raise the awareness, and our colleagues need to be aware that there is such a thing as a pancreatic exocrine insufficiency. And in this context, obviously, you have to take into account the symptoms of a patient. But as we all know, this can be very non-specific. So the diarrhea, the flatulence, The weight loss, the pain can come from any other condition in the abdomen. Maybe not so much the foul-smelling stools and the steatorrhea, but this may not be the case. And therefore, what I like to trigger is really, and coming back to what Marco said, yes, indeed, maybe the fecal elastase test is overrated, but we went at length really to basically teach our colleagues that they should try to have an objective measure, which should then be the starting point for further investigations. And if you handle the fecal elastase test rightly, I think it can be a very good indication, notwithstanding the fact, what you pointed out rightly, that other factors obviously influence whether or not a patient with a given degree of pancreatic exocrine insufficiency does or does not have this insufficiency clinically or symptoms. So, I mean, evaluating the symptoms, number one, especially the stool habits, I think is key here. And then I still, and this is in line with the guidelines, obviously, one should do a fecal elastase, and then obviously further on some more imaging to get a more, how should I say, objective picture of what is the etiology, what is the reason why this patient may have, say, pancreatic exocrine insufficiency.
Something to add, Marco?
Well, I think that's a good point. If you have a patient in a pancreatic clinic where the probability of pancreatic disease is high, obviously you have to be aware of the fact that eventually a high percentage of those patients will develop exocrine pancreatic insufficiency. So you have to be on guard. In a general GI population, it's much different. Mm-hmm. It's about disease prevalence. And what I see, when I guide our trainees, I see that the fecal elastase test has become so popular that people use it very quickly. And I would do a plea not to do that, not in a general population. Because then you get overdiagnosis, strange outcomes, and all of a sudden patients start to get a diagnosis of minimal change, chronic pancreatitis, which gives no clue to anything. So I agree. I think the fecal elastase test has a role, and it's, for us as pancreatologists, a very important contribution to how we manage patients, but in a high probability setting and done at the proper way and interpreted in the proper way. And also instruct patient to get the stools in the proper way to have a good interpretation of the result.
You have pointed out a very important aspect, because we can get crazy if we request a fecal elastase for everyone coming to the GI clinic with a chronic diarrhea, for example.
Exactly.
So we can get crazy, and you tell it very well. So if the probability of pancreatic disease is very low, exclude other things before. Don't do that. If in the appropriate clinical context, in a patient with a high risk of pancreatic disease because of family history, because he's a drinker, smoker, whatever you want, because it has a typical pancreatic pain, okay, that's fine. Because he's losing weight, okay, but not generally speaking, then we can get absolutely crazy.
I would challenge this.
Yeah. And if I may, Enrique, in case of diarrhea for people, usually dilution for the elastase dosage, and it could be low, but without any pancreatic insufficiency. So sometimes when the indication is not appropriated, so we have results which cannot clearly be assessed and false positive, absolutely.
This is very important. Matthias, do you want to add something?
I want to challenge this. I mean, the studies from Germany, for instance, have shown, and our own studies, that you can have a very low fecal elastase in patients who are asymptomatic, and that would still be in line with a pancreatic exocrine insufficiency. And this is coming back to another aspect which you mentioned in your short introduction, Enrique. And we all know these patients. You know, if you ask a patient who has really, I mean, a proven pancreatic insufficiency and maybe say some asymptomatic, that is painless chronic pancreatitis as an underlying cause, and then you ask the patient, what is he or she eating? And then it turned out that the patient unconsciously has avoided fatty meals and just stick to, say, potatoes and maybe some pasta or something. I mean, these patients exist. So I still think that even in a patient who has less symptoms, the fecal elastase test eventually can guide you in the right direction.
Okay, so, now you have opened a new scenario.
Okay, but and just saying, I really believe in the fecal elastase test as a screening test. Having said this, I concur with Marco said that obviously it has to taken very carefully into account the circumstances and what the patient is coming with. And we also do know, maybe discuss this a little later, the patients who have IBS and low fecal elastase and all of that. But I would very much make the point, do the fecal elastase test at least in symptomatic patients. I think that is one of the things we should agree on today.
Okay, I will follow your idea. Now, let me focus on a patient with a diagnosis of pancreatic disease. So we know that the patient sitting in front of us has a chronic pancreatitis, pancreatic cancer, surgery, whatever you want, but a pancreatic disease. Of course, we need to think on pancreatic exocrine insufficiency because that is the scenario. But symptoms are not so, as you said before. That's why I told you that you have opened a new scenario. Symptoms are not so sensitive because, I mean, we review the literature and the mean is that about 50% of the patient has symptoms of PI, patients with PI. So 50% are symptom-free because they adapt the diet to avoid symptoms. And in that scenario, again, we can focus on chronic pancreatitis if you like. What is the role of nutritional markers, Vincent?
So I think that
for diagnosis, I mean.
Yes, for diagnosis. So if there is absolutely no symptoms regarding probably exocrine insufficiency, and I know that the patient has chronic pancreatitis, me, in my clinical practice, I'm used to tests, so nutritional tests, I mean vitamin, and so we can talk about that if you want.
Yes.
So I do it twice a year, just to monitor and to be sure that there is no deficiency. And if there is some deficiencies, nutritional deficiencies, and I suspect that there is exocrine insufficiency, yes, I want to confirm the diagnosis, I will test fecal elastasis. But for patients, clearly for pancreatic disorders and chronic pancreatitis, I'm used to do that. Because, as you said, sometimes we have patients with clearly chronic pancreatitis without any symptoms because they adapt what they eat, because they just don't want to have symptoms, flatulence and so. And it's not clear if there is or not exocrine insufficiency. So, and especially for any cause of chronic pancreatitis, I mean, and we have to be very careful, especially in young adults in case of genetic pancreatitis, especially because they will have usually some deficiency all along their own life. And we will find osteoporosis in very young people, for example, and really profound deficiencies. So I'm used to do that. If clearly diagnosis of chronic pancreatitis is clear for me, I do that just to not to be sure that I could diagnose pancreatic insufficiency.
So for the nutritional evaluation, because this is one of the part of the diagnosis of PI, and also very important to monitor the efficacy of the therapy, as we will discuss later on. Normally, we include body weight, weight loss, some anthropometric markers, and also blood markers. And in the blood markers, our usual recommendation, I mean, in our group, and this is what we have been publishing, and I wanted to know your opinion for the rest of the audience. So we always include proteins, which are very important, like albumin, prealbumin, retinol binding protein, or transferrin. We also include fat-soluble vitamins. Everybody agrees on that. And also micronutrients. Is it the same thing that you do in your clinic, for example, Marco, or do you think that there is something different?
Well, we do it at this point in time, but we do it also mainly for research purposes. It is, if you take it all together, it's quite expensive what you do every time with regards to laboratory testing. So I think we as pancreatologists have to come up with the justification to spend this money to do this. And of course, I always try to look upon this from a kind of clinical point of view. Can I persuade the patient in front of me taking pancreatic enzymes? And for me, and I think you have written about this many times already, there are two patient groups. The patient with clear exocrine pancreatic insufficiency, you give them enzymes, and the next time they come to you, they're so happy and you're the best doctor in the world. Mm-hmm. And these patients will continue with their medication forever. They don't want to part with it. But how do you persuade a patient that has no clinical symptoms, maybe a few deficiencies in his or her lab results, to start using these enzymes every day and so forth? To me, that's a dilemma. I find it very difficult. Also in particular, because if you take 10 people in the waiting room for other diseases, they will also have deficiencies. So we have some studies now showing that indeed in pancreatic patients, these deficiencies are of higher significance and they're of higher frequency. So they're more important. But I struggle personally, and I have tried with a few patients to get them to use pancreatic enzymes. And to start it, that's not the point, but to keep them continuing to use the enzymes is a very hard thing. And the problem is, of course, we have indirect evidence that exocrine pancreatic insufficiency that just doesn't give automatically symptoms is prognostically a bad sign for a patient, in particular with regards to cardiovascular disease, for example. But it's all indirect evidence. And again, I don't know how my colleagues do this, but to persuade patients to take, 6-9 capsules per day, if they don't have any symptoms, that's not easy.
It is not. You have moved to the part of the therapy. We will discuss further on that if you don't mind, because this is a very important point. So we have been talking about symptoms, about nutritional markers, but we said almost nothing about function tests. I mean, we are talking about a pancreatic dysfunction, and we said nothing about function tests. We have been talking about fecal assays. Matthias, anything else? Or, I mean, being very practical, okay? We are talking about practical gastroenterologists, practical surgeons. Should we say anything else about other tests? Are there other tests that we should consider, or today the only option that we have is fecal assays? Marco told before about the fecal fat quantification.
Okay, let me first of all underscore that I consider the nutritional parameters and blood markers very important. We do this as baseline, and then not like Vincent twice a year, but once a year. Yeah, when we see our patients on a regular basis, and maybe in the end we'll come back why we all think that following up these patients at least once a year is very important in the long run. Now, with regard to the question with other function tests, we normally stick to the fecal elastase. We don't do the fat measurements, and you can also measure other things in stool, which we are not doing. We have also mostly a baseline MRI. And since we have a radiology department who's very good at that, we spend the money, which is expensive, I have to say, to also do a secretin stimulation during the MRI, MRCP. And this, as you know, will give you an indication semi-quantitatively of the bicarbonate projection of the gland, which together with the fecal elastase and the overall imaging is also indicative of a function test. Now, this is more or less the routine at our place. Mind you, we are a tertiary center and see patients from all over Sweden with pancreatic diseases. So that may not be the routine at any other center, number one. Number two, obviously you can do other function tests, which maybe we talk about a little bit later, namely the breath test. which we also do, but I have to admit, not in every patient, to establish the diagnosis of pancreatic exocrine insufficiency.
Well, you know that the breath test is now not so easy commercially available outside clinical research. For research, we do it, but no longer for clinical practice, except in some difficult patients. And the point is, at the end, we have the fecal elastase, because secreting is also not available, Matthias, in the majority of the countries. So this is also an issue, not only for pancreatic function, but the MRI with secreting is much better than without secreting for many reasons, and it's not available. So this is also not for real life. And at the end, we are talking about fecal elastase, except fecal fat. And this is what Marco said before. And I would like to talk a little bit more about it. We know that this is a non-specific test, but if you do it well, I mean, at the end, you're evaluating digestion. And if the patient has a high probability of PI, obviously the pancreas should be responsible for maldigestion in these patients. But it is cumbersome, it's difficult to do, it's difficult for patients to comply with. And my questions to you is, because this is something that I have seen many times, colleagues of us that used a single sample of feces to measure fecal fat, like steatocrate, to measure in an isolated sample of feces, or 24 hours, if you like, feces. Yeah. Any experience on that, Vincian, or any opinion on that?
So personally, I don't do that. The only one situation I propose to assess fat into stool is the case of a patient who with high level of enzyme and there is still symptoms, and I clearly don't understand. So even after inhibition of the secretion, so we'll talk about that, but and to have a rollout overgrowth, microbial overgrowth, and there is still symptoms. And it's not very clear if it is due to steatorrhea or not. I propose to assess the fats into the stool in patients who take enzyme. So they take enzyme, and I want to be sure that there is still steatorrhea in this patient. But as you said, it's very difficult, because if you want to do it well, so you have to do it for 3 days.
Yeah.
You have to keep your stool in your at home. So welcome for all the family. So all the patients say that it's quite crazy to do, and it's not usually do very well. So clearly, it's very rare that I have to do that. Very, very rare. In a specific case of patient with take enzyme and symptoms are not controlled, even if I have ruled out all the other case of enzyme inactivity.
I think that it is important today to say that a single sample of feces is not useful at all to evaluate fat digestion. So you can forget that. You can save money and time avoiding that. But Marco told us about a short version of the 72 hours stool fat collection. You were talking about 48 hours?
Yeah, so what we sometimes, 48, I mean, try 2 days run-in and 2 days collection. So it's a shorter version of the 3 days, which seems to work fine.
Yeah. Do you have any data on that?
Sorry,
and is that better for patients that 72 hours? Because at the end, they should do it.
Sorry, okay.
Okay.
I'm recovering from COVID. No, I don't have specific data for that, but we have been using it for years already.
Let me come to the end of the part of the diagnosis of PI, or coming slowly to the end. One of the most difficult points, we have been talking about symptoms, nutrition, and fecal elastase. And one of the most difficult points is to interpret the result of the fecal elastase. If the result is supporting our thoughts, then everything is fine. If I expect a low fecal elastase and the results that I get is low, I'm happy. On the contrary, if I'm expecting a normal fecal elastase and the result that I get is normal, I'm happy. But frequently it's not the case. So how to interpret the fecal elastase result. This is a very important point to discuss today. And basically, taking into account the pre-test probability of PEI in different diseases. Do you want to comment on that, Matthias? Because Marco
this is a very important issue in clinical practice, obviously. The first thing is that you advise the patient how to take the sample. I think this is the pre-test thing. Obviously, if you have watery diarrheas, this is not the best material to take the sample from. So this is the first thing we instruct our patients to do this in the right way. And then if it is in a gray zone or around 200 something, we tend to repeat the test as well. Okay, it's simple, it's cheap, and it's non-invasive, so patients can be asked to do this again, and this is what we do. Now, as you pointed out before, obviously the test needs to be seen in light of all the other things which can contribute to the proper diagnosis, namely the imaging. But we have to accept that there are patients who, with all limitations to the fecal elastase test, will end up in an area where, you know, they may have, say, 200, 220 micrograms per gram, which would put them right in the quote unquote still normal area, and they still have symptoms. And then now we're jumping to the treatment. Maybe then one can try whether the symptoms would be improved with enzyme replacement therapy, isn't it? You can have the other way around, obviously, that you are just below the 200, and in this zone between 100 and 200, it is still, the test is unreliable. I think you can only, and your and ours and the data from Italy showed this very nicely. If you have fecal elastase below 100, I think you can rely on the test. You know, then I think everybody would agree that this is indeed, if the sample was taken in a proper way, pancreatic exocrine insufficiency.
Let me share with you again one slide.
I know what's coming now.
We have been.
Yeah, no, I know too what you want to show us.
We have been, well, we are now doing a systematic review of the role of fecal elastase, specifically for the diagnosis of PI. And the mean sensitivity and specificity is what you see on this slide. So the sensitivity is 85%. This is the mean according to the different studies using CFA as the gold standard, the coefficient of fat absorption. And the specificity is just 64%. So we have different probabilities of PI depending on the disease. And what you see here below is what we can take as this is an approximate value according to what has been reported, from 20 to 90%. Look, if we have someone with a pancreatic cancer with a tumor located in the head of the pancreas, or chronic calcifying pancreatitis with a very high probability of PEI, and if fecal elastase in that scenario is low, then the positive predictive value is between 90 to 95%. So fecal elastase is telling you, okay, your suspicion was PEI and you were right. But if in that scenario of high pretest probability of PI, the fecal elastase result is normal, normal means above your cutoff, because the cutoff is different in different studies. Could be higher than 100 or higher than 200. In that case, the negative predictive value is just between 30 to 50%. So a normal fecal elastase in a scenario of high pretest probability of PI does not allow you to exclude pancreatic exocrine insufficiency. And let me come to the contrary. So people with a low probability of PI, someone with a chronic non-calcific pancreatitis, for example, or after acute edematous pancreatitis, if you like. In that scenario, a normal fecal elastase allows you to exclude PI with a negative predictive value of 95%, something like that. So if the pretest probability is low and fecal elastase is normal, you can say, okay, that patient has not pancreatic exocrine insufficiency. But if in that scenario of low probability of PI, fecal elastase is low, the probability of PI is very low. It's between 20 to 50%. So again, if the probability of PI is low, a low fecal elastase does not allow you to confirm the diagnosis of pancreatic exocrine insufficiency. And I think that's important in order to understand what is the role of fecal elastase in clinical practice. And now, let us come to the end of the diagnosis. Let us put everything together. So I have the patient sitting in front of me, for example, chronic pancreatitis, and I have evaluated symptoms, I have evaluated the nutritional markers, and I have evaluated fecal elastase. How do I use all this information? How can I put all these informations together to make the diagnosis or to exclude pancreatic exocrine insufficiency? Vincian, do you want to talk about it?
Because yes, I can. Yeah, I understand clearly what you show. So just previously, but I think it's, as you say, it's that when you summarize the symptoms, biological marker, I mean nutritional markers, and dosage, elastase dosage, and of course symptoms, I think you can assume that there is pancreatic insufficiency. I mean, we know that in chronic pancreatitis that you mentioned just previously, we know that it is a very frequent complication will appear during the natural history of the disease. So when you have symptoms, when you have dosage of fecal elastasis, which is clearly under 100, and if you have obviously nutritional markers of malabsorption, I mean that clearly you have to assume that there is a pancreatic insufficiency. But even if there is no nutritional marker of insufficiency, I think that it's better to give some enzyme more than the patient will need, that to give less that the patient will need, especially in case of chronic pancreatitis. I mean, I think it's not really a problem if in some case you are wrong and you give enzyme and probably the patient won't need so much, I think. I think it's not clearly, so in clinical practice, I think that's, for me, it's important to give more enzyme, even if sometimes you are wrong, because the dosage is not, there is a false negative and so, but I think that's better that sometimes you mistake and you give some enzyme, especially in case of pancreatic disorders. And what I want to highlight is that in physiology, every time we eat, we have around 500,000 enzymes, which is secreted by pancreas. And we know that to have some steatorrhea, it means that we have less than 90% of the secretion, which low. So it means that there is a high rate of enzyme, which there is a secretion of high rate of enzyme every time we eat in physiology. So that's why sometimes it's difficult, and there is some results can be different regarding all the patients we have, especially when there is pancreatic disorders, because there is so many enzymes which are normally secreted by pancreas.
You put before on the table a very important point, and I want to underline that. So I think we have been talking about a quite complex condition. So pancreatic exocrine insufficiency is not as easy as just having a low pancreatic secretion. And we have said before that we don't have the test. So there is no single test to say yes or not. So we don't have it. So it is important for everyone who is attending this symposium that the evaluation of symptoms, nutritional markers, and fecal elastase all together is important to understand what is going on with a specific patient. But you pointed out a very important point, Vincian, and if I'm not sure, because sometimes it's not so easy, if I'm not sure after evaluating everything, if the patient has or not pancreatic exocrine insufficiency, what is the disadvantage of leaving that patient without therapy in case the patient has PEI, or the contrary? What is the disadvantage of treating someone without PI because I was not sure. And this is something that we need to consider many times in clinical practice. This is a very, very important point.
And
Let me
this is
move.
a comment actually, which came here in the chat, as you have seen, from also a quite renowned pancreatologist from Liverpool, Robert Sutton, who says he's then treating his patients, right? And I think that's exactly, I think, the way one should handle this. If in doubt, wouldn't you agree? Instead of not treating a patient, Enrique?
Yeah, I will fully agree. You know, the pre-test probability is very high to make the diagnosis. We don't do any tests in patients after pancreatic duodenectomy because the probability of PI is so high. I mean, of course, I evaluate symptoms and nutritional markers because I will use them for the follow-up of the patient. But we don't need fecal elastase in this patient.
No,
or someone with a pancreatic cancer, the tumor located in the head of the pancreas, obstructing the main pancreatic duct. I mean, we don't lose time. We assume that these patients, because the probability is so high, we assume that this patient has PI. And
this is another comment of Claudia Melentin from Switzerland, who is actually precisely asking that. And I mean, we are now already in the treatment thing about why this is not standard to treat patients with pancreatic enzyme replacement therapy and pancreatic cancer. But I can refer her to the ongoing guidelines which we are developing, isn't it? Which will put an answer to that.
So there are a lot of open questions yet, and you should be aware that we are working hard on developing a European guideline, which has been proposed by the European Pancreatic Club and supported by the UEG on pancreatic exocrine insufficiency in different conditions. And I hope that we will be able to deal with all these questions.
In all conditions, one can say.
In all conditions, you are fully right.
We know of.
We have a bit more than 30 minutes to talk about therapy. We need to talk about therapy.
Absolutely.
And I told you at the beginning that we have two main pillars, nutrition and enzymes. Let me start by talking about, I mean, we are not dietitians, but at least to talk about nutritional recommendations in patients with pancreatic exocrine insufficiency. Matthias.
Yes, I mean, again, coming from a tertiary center here, we involve a dietitian very early on. And this is something which I took up from the Australians, actually, when I was visiting there many years ago. And it's also part of the guidelines, Enrique, you and I issued, together with Vincent, of course, that one should consider involving a dietitian. Now, in contrast to the early, I mean, now 10, 15 years back, we of course recommend the patients should eat what they need. And this is particularly important, I think, for those who have diabetes. They should not avoid fatty cost, that they should take sufficient enzymes to digest the food they need to keep up their weight or to gain weight, as a matter of fact. We also said that maybe they should eat regularly, which is for some of the professions a problem, obviously. But nevertheless, if they would like to follow a normal diet, that is completely okay, and they should adjust the enzyme supplementation to their diet. And also what we have learned is if they do that, normally they don't need special supplements, with certain exceptions, which I think we can maybe discuss in a second step. So yes, I think dietary advice is good, can be given by the gastroenterologist, but sometimes it's also advantageous to involve a professional who is then helping you as the physician to do the best for your advice for your patient.
I fully agree with you, and probably we can focus on something that is frequently recommended by general gastroenterologists and some pancreatologists, I must tell you, about a low-fat diet.
Yeah.
And this is something that we need to...
Non-che.
Exactly, to say this is not a good recommendation at all.
Yes.
It is not that it is the same to do it or not, to recommend it or not. It is negative for the patients to recommend a low-fat diet in this context. And Vincent will for sure agree with you about the need of a dietitian, because he's dealing mainly with patients with pancreatic cancer. So
Yeah, me too.
Yes, I completely agree with Matthias and you, Enrique. So we refer a patient to dietitian to help them just to adjust diet if needed, because usually they came and they don't eat fat anymore. And clearly I said, no, you have to eat normally. And clearly you need fat also. And what I want to say is that, so I used to just to explore my patient to do, as I say, twice a year, so some dosage of vitamin, not only A, D, E, but also B9, B12, and so. And usually, not usually, quite all the time, I can see that there is insufficiency, especially in B12, B9, even if patients take regularly enzyme, and we can see that symptoms are controlled. And I have to give them more vitamin D, vitamin B9, vitamin B12, A and E regularly. And that's why I do that twice a year, because do it twice a year, I can give them some supplementation for specifically for this vitamin. And so I know that the study was made by Matthias' team, I think, but it's clearly known that even if you take your enzyme regularly, you can have insufficiency, deficiency in a lot of vitamins.
Absolutely. And I mean, particular vitamin D is a problem in the Northern Hemisphere, as you know, maybe not that much in the Mediterranean areas. So that is something we tend to supplement rather regularly, I should say. And of course, if there are deficits, then we supplement those. We had the other day a patient with a very severe vitamin A deficiency. It was really a problem to get these drug IV. But I mean, you can see these deficiencies. So yes, I think they need to be treated separately. And I mean, we follow this nutritional panel, which again was, I think, initially promoted or investigated by you, Enrique, with some kind of additions. I think vitamin D was not in your original panel, but this is something which we obviously take up here in the Northern Hemispheres in Sweden.
So we have been talking now. I wanted to talk about that a bit later, but since the topic is now on the table, I will talk about it. And is how often should we monitor these patients? We are talking about nutritional markers. We can also talk about symptoms, but we said before every year, but obviously every year is in patients with chronic pancreatitis probably who are stable, and we follow them. We visit them once in a year, but this is not the case in pancreatic cancer. If you visit these patients once in a year, probably you will not see them again.
That's a different story.
So the disease is important, and this is something that I would like to discuss with you. How often should we monitor these patients? And also the degree of malnutrition probably is important to decide whether we should visit this patient in 1 month, 3 months, 6 months, or 1 year. Not Vincent?
Yes, for chronic pancreatic disease, not for pancreatic cancer, but for example, chronic pancreatitis. For my patient, I see them one time a year, but I ask them to perform biological markers twice a year. So they send me all the biologicals, and so when I have to give them supplementation, I send them support for supplementation. But I insist in these facts that sometimes twice a year for biological marker, it's important, because for patients, even if I ask them to take vitamin D, because it's also a problem in France, even if it's more sunny, for example, I can see that there is really great deficiency in all my patients, but not only vitamin D, A, E, B, B9, B12. And what I want to emphasize is that for some patients with exactly the same disease, I mean chronic pancreatitis, sometimes some patients have to take 1 dose of vitamin D per month, and sometimes 1 dosage per week. Sometimes I have this kind of patient, and I try to be in the range with some difficulties. But what is important to tell the patient is to take this vitamin during the meal with the enzyme, because if they take it when they think to take the vitamin, it goes directly into the toilet, I should say. So it's very important to tell the patient to take this supplementation during the meal with the enzymes.
Enrique, can we just have a look at the chat and
I had the chat opened, and there are two questions that I wanted to ask you, but I'm going step by step. And before coming back, well, there is a question that we can answer now because we have been talking about the nutritional support. And the question to Matthias is, you have been talking about referring the patients to a dietitians. Do you do it for every single patient, or only patients who are deeply malnourished, or do you have a score to say this patient yes and this patient not?
I mean, we have the luxury of having the dietitian virtually in our outpatient clinic. And even for those patients who are coming from farther away, which is a majority of our patients, on top of those from Stockholm, they can see the dietitian the very same time they meet one of us. Okay, that's a certain luxury. But we do not do this in every single patient, but in those who have, say, an exocrine pancreatic insufficiency, either severe or where on returning to the outpatient clinic, it is not sufficiently treated by just giving enzymes. Okay, these are the typical patients where we then, as a default, let them meet a dietitian. Under the pandemic, obviously, even that is sometimes happening remotely via video meeting with those patients, something which we have developed during the last 2 years.
Matthias, Vincian, a very important question because we don't have so much time. So we have the patients diagnosed with PI, and now we need to prescribe enzymes. What dose? What initial dose? We always recommend the 40, 50,000 with main meals, but the same for everyone, or should be different in patients with pancreatic cancer, should be different in patients after surgery? How do you do it? How do you deal with it, Vincian?
So as I told you just previously, I think that low dosage is, there's no indication for low dosage because as I told you,
what is low?
For me, normal secretion, as I told you, is around 500,000 units of enzyme per meal. So if you want to have an action, so less than 40 or 50,000 per meal, I think it's not available. So you have the minimal dosage for me, it's 40 or 50,000 per meal. That's
for pancreatic cancer as well?
For everyone. For everyone which has, for me, exocrine insufficiency. But of course, you have to adapt regarding your patient. If there is surgery, if there is pancreatic cancer with chemotherapy and sometimes association and of malabsorption and so, if they had radiation, for example, and regarding this, there is a complete atrophy or many calcification. And I ask the patient to adapt to the symptoms. But not only the number of stool, but also if there is still flatulence, if there is, if I can see that the nutritional biomarkers are not very good. So I have no fear to really increase the number of enzymes. Sometimes I ask patients to take 80 or quite 100,000 units per meal. Sometimes they need it, really, especially after when you get surgery, pancreatic surgery for pancreatic cancer, you get sometimes radiation, chemotherapy, and you get surgery with lymph node, which was, I don't know the English word for that, but you have some diarrhea due motrice. Excuse me, I don't know the English word for that. Yes, so you have to give it a lot of enzyme, and you can assume that after surgery that maybe you can open the pills if needed, you can adjust what you give to your patient. And it's important to tell them to take enzyme also when they just eat something just when it's 10 or 4 the afternoon, and when they eat that they should take some pancreatic enzyme.
I tell you what we do in our clinic. We have two different profiles of patients. One are patients with a benign condition, like chronic pancreatitis or after acute necrotizing pancreatitis, and with normal anatomy, people who were not operated on. These patients, we start with the standard dose that we recommend in the guidelines, 40 to usually 50,000 with main meals, 25 with snacks. But I mean, you probably will agree with me, this dose is normally not enough in patients after pancreatic duodenectomy, for example, and in patients with pancreatic cancer. In patients with pancreatic cancer, there are several issues. First of all, they are in a catabolic state. They have a high nutritional requirements, nutritional needs, and we don't have time. So in chronic pancreatitis, you can start by giving 40, 50, and then you have time to increase the dose if needed. But in pancreatic cancer, the time is limited. So we always start by giving, today, we start by giving 70,000 units with main meals. What do you do, Matthias?
The same. We just recently published a paper on the cachexia in pancreatic cancer. And I mean, clearly the nutritional status, and this includes obviously the pancreatic function and digestion, are key. There are very nice studies from the UK, Roberts, who nicely showed in a systematic review also that giving pancreatic enzymes to pancreatic cancer patients as a single effect is as good as giving chemotherapy or surgery as a single factor, okay? So clearly, and this is answering the question of my colleague Miroslav Vojavinovic here, those get enzymes right away as soon as we are catching them, you know, and typically even before surgery, if they are undergoing surgery, because, you know, obviously they have already lost, say, 10, 15 kilograms the last half year due to the malnutrition. So, I mean, that is really, and then even if they are not operable, the ones with the pancreatic cancer clearly have, as you showed very nicely, a high probability of pancreatic enzyme insufficiency. So they need to be treated, one can almost say almost aggressively with regard to their digestive capacity, standing in the missing capacity of the pancreatic gland in itself.
Therefore,
so, just to
tell me,
excuse me, just to see to answer in case of pancreatic cancer, you know that in the large majority there is no surgery because there is already metastasis, and so when we diagnose pancreatic cancer, one of the first questions is regarding the aspect of the stool of the patient, and has said Matthias to be very aggressive and to give enzyme because they lost many kilos, they will have chemotherapy, and they will need to have a high level of nutritional markers to not to have too many side effects. And the second thing I want, two other things. The second thing is that you will see your patient every 2 weeks regarding the chemotherapy protocol. So it's very easy to adapt the dose, and we don't care about fecal elasticity, in my opinion. In that case, we have to be guided by the symptoms of the patient, and you can adapt every 2 weeks the dosage you give to your patient. But what we have to know is sometimes they need morphine because they are very, very painful because of pancreatic cancer, which could lead to constipation. And sometimes they just don't want to take so much because they have already symptoms due to this constipation. And so it's very important to try to manage morphine, constipation, enzyme, because they would say, I don't want your enzyme because I already very painful because of constipation, but I need my morphine. And so we have to manage for laxative, for constipation due to morphine, and they could accept to take enzyme. Yeah. That's a very important point.
Let me ask you something. We have cleared that the initial dose is not the same for everyone. So for example, in patients with pancreatic cancer or after surgery, it's not the same, it's higher to start with. We have been talking about symptoms and monitoring symptoms and nutritional markers. My question now to you is the dose the same in patients according to the degree of malnutrition? So you get the first results and the patient is deeply malnourished. Should this patient get a higher enzyme dose from the very beginning compared to someone who has a mild malnutrition, if you like? Is that something that you take into account or not?
Well, I would, first of all, I mean, if the basis is the same degree, quote unquote, of pancreatic insufficiency, then the enzyme supplementation should take care of that. So the question really is whether such a patient is indeed taking the enzymes. And I think that would have been the question I would ask first rather than without asking.
No, but I mean before starting the therapy as initial dose.
I don't think so. I think you should start with an ordinary dose, and then see how the patient is reacting. Again, there are studies out there showing convincingly that if you give pancreatic enzymes, normally the malnutrition is improving. Okay, so obviously we discussed that if there is a very severe deficiency, say in vitamin D or even trace elements, vitamin A, something like that, you have to supplement that. You will not, I think, mend this by giving more enzymes. I don't think so.
I fully agree with you. Let me move to the situation in which we prescribe the initial dose whatsoever, 50, 70, whatsoever, depending on the disease. And the clinical response is not the one that we expect in terms of symptoms or in terms of nutritional markers. What is your second step? Do you add a proton pump inhibitor or do you increase the dose? What is your recommendation to all the participants in this symposium?
So for me, I really adapt my practice to the symptoms of the patient, not really regarding the just nutritional biomarkers, for example, because even if patients have no diarrhea, no steatorrhea, for example, they could have still some nutritional deficiency. So I prefer to give them some supplementation if needed. So for this, I will adapt the dosage if there is still diarrhea, for example, or flatulence and so, and I will give more enzyme. And if it's not enough, I will propose to an inhibition of the gastric secretion, because we clearly know that it could help for enzymes to be great, with a great efficacy. And if not, or if patients are very well and after surgery, or I don't know if there is the balance is not as usual, we know that there is a higher risk to have some microbial overgrowth, and which could lead to enzyme inefficacy. So sometimes I would propose some antibiotics therapy test.
That was the next question, Vincian.
Oh, sorry.
But I mean,
it's very good. It's very good.
Let's stay here for a minute. I would throw in a cost effective thing here. If you increase or double the enzymes, this is much more expensive than giving a PPI. So in practice, what we are doing, we're giving a cheap PPI first and then see whether this is improving and then increasing the enzymes. That doesn't say that the other way around is also working, obviously.
I agree with you. And this is what we do usually. Generally speaking, obviously we need to individualize, but generally speaking, we add a proton pump inhibitor as a second step. And actually, let me tell you something, and you will disagree with me if you like. In patients with pancreatic cancer, with the tumor located in the head of the pancreas, obstructing the main pancreatic duct, you see that very nicely with a dilated duct, we add the proton pump inhibitor from the very beginning, because we know that the pH in the gut is acidic. So we don't wait.
I do not disagree with you.
So you agree with me. That's yes. Very good. That's very good.
We agree
Hello,
with
Marco.
You.
Welcome back. Welcome
Thanks.
back. Okay, and now coming back to the point of Vincian, regarding the point in which we increase the dose of enzymes, we add a proton pump inhibitor, and again, clinically, the patient is not doing well because of diarrhea and so on. And we always think on bacterial overgrowth on SIBO. We know that PI is a predisposing factor for SIBO. In that case, do you perform a breath test to confirm the diagnosis, or do you prescribe antibiotics empirically just because of it makes sense? And what kind of antibiotics? And now you can answer, Marco.
No, we never start with antibiotics. We do a breath test to start with. So we have the C14. There is C14 octanoate we have ongoing, and we are now experimenting with a new test that we are trying to perform. And quite often, when we ask for this test, the test comes back negative. And we have not published this. We have done a trial where we then still did give patients antibiotics, and the majority, 80% of the patients, did not respond to the antibiotics. So that was for us a means to find that our strategy was the right one, to do first a breath test before doing anything with regards to antibiotics.
Do you do a breath test before, Matthias?
No, we don't. We treat right away.
And what kind of antibiotics?
Oh, you got me on that one. Try first the one which is not resorbed.
Rifaximin.
Yes, that one.
Rifaximin.
Yes, that's what we take.
This is what we usually do. Just trying to solve the problems of the patient. We can do the breath test as well, but it takes time.
Exactly.
And the patient is not doing well. So, but scientifically speaking, and probably doing things well, it will be better to do a breath test to confirm. Also, the accuracy of the breath test, of the hydrogen breath test, is not as good. So it's always the uncertainty that we have in that situation. What is your opinion, Vincian?
So we don't perform breath tests in France usually, because it's not easy to obtain very rapidly. So I prefer to propose a therapeutic test with 10 days antibiotics in my patient. But I know that if to do it well, we should do that. But we don't have a rapid opportunity to do that. So in clinical practice, I propose the antibiotics test.
Okay.
As Matthias, exactly the same.
Can I ask you to give me a very short answer to 3 practical questions in clinical practice? And I have a patient with chronic pancreatitis, pancreatic exocrine insufficiency, and the patient is pregnant. How to deal with it, Matthias? Short
Nothing
answer.
wrong with giving enzymes to that patient as well.
Okay, and you all agree. And my second question is, the patient cannot swallow the capsules, and now the 35,000 capsules are not small, so the patient cannot swallow the capsule. What do you do, Marco, if you like? I mean, I don't care.
I let them open the capsule, of course, with the proper instructions in order not to have premature degradation of the enteric-coated layer of the micro units. But with proper instructions, that is well doable. The only thing is, if you have to do that with every meal and also in between meals, you impose a lot to the kind of life of a patient to deal with his or her condition. But if he or she cannot swallow, but still needs the enzymes, that's what you have to do. And again, if then there is a good solution to the complaint of the patient will understand and will adhere to the special precautions with regards to taking the minute units with some yogurt or apple sauce or whatever.
I tell you.
By the way, opening up is beside not being able to swallow, also a good measure, particularly in patients who underwent surgery, in my experience. Sure. So.
Well, I'm not so convinced on that, but leave it open. I mean, you can do it if you like. opening the capsules, the patients can swallow directly the granules, the pellets, or, and this is something important that you say, Marco, they should take it, they should put it in an acidic milieu.
Absolutely.
They cannot mix it with standard food. Otherwise, the enzymes will be released in the food and will be inactivated as soon as they are in touch with the gastric acid. What we recommend is always natural lemon juice. And you know why? Because all the juices in the market are buffered in a way that they are more palatable, you know? So you can use apples, but apple juice is different depending on the apple. I mean, the pH is not always the same. So that's why I prefer to recommend lemon juice.
Yeah, but what patients tell me what they like about using yogurt or applesauce is that it's sticky.
Yeah,
exactly.
And that it means that if you open the capsule, that the micronutrients are contained within the substance. And for them, it's easier to swallow. And of course, you point out right, it's also very important to instruct them that no mini capsule should be left behind, because then inevitably they will have a painful spot in their mouth. It's not easy. You know, I understand from patients, if you have to do that a few times a day with every meal, it's not an easy instruction. But, you know, if that's the only way you can make it work,
we have 4 minutes. And still some open questions, but there is a question here in the chat by Robert Sutton that we need to discuss as the last one in 4 minutes, and we are convincing pancreatologists, surgeons, gastroenterologists, experts in pancreas to prescribe to treat properly, to diagnose and treat properly pancreatic exocrine insufficiency at the right dose, right nutritional support, and so on. But in the studies, and one of them is from your group, Marco, this is not the same in general gastroenterologists or general practitioners. What can we do as experts to improve these results, to improve the adherence to guidelines, not just by experts, but by general gastroenterologists or even general practitioners? And probably, Marco, you are the one to start.
Yeah, that's a very good question, of course, and a very difficult question to answer. I think the most important thing is to try to make the patient responsible for his or her own treatment together with the doctor, not to be doctor prescribing something, give the recipe to the patient and think everything will be fine, because in my experience, it's not fine. So in the Netherlands, we're now doing a huge study where we are trying to instruct patients with regards to their therapy, not only by the doctor, but also by a nurse who's even visiting patient at home during the first prescription, to give them a clear indication why and how they should use the enzymes for now and maybe for the remainder of their lives. So investing in a patient, in particular in the first weeks of his or her treatment, because we all know in the majority of cases, pancreatic enzyme therapy is for life, is important, because that effect will resonate for as long as possible. Educational programs, we find that within, at least in the Dutch population of patients with chronic pancreatitis, we give lectures every year with regards to, in particular, exocrine insufficiency. By far, it's the most sought subject by the patient groups to get information about exocrine insufficiency and enzymes. And every time we go there and we give talks, there are different patients and also family members who come to hear these talks. Because as we are talking about this, we all think this is very, you know, we understand everything about physiology and why you should do this and that and pH and high and low. For patients, it's not an easy subject. And I've also learned that at least you have to explain what you are saying to a patient 2 or 3 times and include a dietitian, which is now a standard part of our workup with regards to these instructions. Because that all helps in getting the right outcome for the patient. And we know all in medicine in general, if you prescribe a medication, don't believe that everything you prescribe is actually taken by the patient and even not taken at the proper instruction by the patient. So, and that goes by far for pancreatic enzyme therapy. So proper education and showing the patient that it is for her or his welfare, I think that's the most important thing to pursue.
I think there is no better way to close this symposium. Education is absolutely needed, and to invite GPs to collaborate as it has been suggested in the chat. So I hope that you have enjoyed the symposium as much as I did. It has been really great. A new way to do it, this roundtable, even virtually more difficult. And I hope that all the audience have enjoyed it. Thank you, Matthias. Thanks a lot, Vincian. Thank you, Marco.
Thank you.
We continue connected to the EPC. Thank you very much.
Thank you.
Thank
See you
you.
later.
Bye-bye.
Bye for now.
Ciao, ciao.
Bye.